Hello, welcome, and thank you for your interest in learning more about how healthcare professionals can identify and combat human trafficking. My name is Jaime Lee. I've been a communications professional for more than 15 years, and I have the privilege of serving as your moderator. The presenters here disclose that there is no conflict of interest with the material presented. There's been no financial support or contributions with the development of this presentation. Human trafficking is a global issue. This crime is underrecognized and underreported across the world, including in the United States. Healthcare providers are in a unique position to identify potential victims, so it's important that providers be properly trained on how to identify and assist trafficking victims. In 2019, the Texas legislature passed a law to require that healthcare providers who provide direct patient care receive training in identifying human trafficking. The legislation, known as House Bill 2059, requires anyone who is licensed under the Texas Medical Board, the State Board of Nursing, or the Health and Human Services Commission to receive continuing education on human trafficking, prevention, and education. You can visit the DHHS website for a list of approved courses. During this 1-hour session, you'll hear from 3 experts on the topic, who I'll introduce now. First, Dr. Kevin Clark is an associate professor and associate director with the School of Health Professions at the University of Texas MD Anderson Cancer Center in Houston. In 2021, Dr. Clark was tasked with creating a human trafficking prevention education webinar that was approved by the Texas Medical Board and available through the American Society of Radiologic Technologists for all medical imaging and radiation therapy professionals. Thank you for being here, Dr. Clark.
It's a pleasure to be here. Thanks for having me.
We're also joined by Dr. Susan Lee. Dr. Lee is an accomplished and experienced nurse leader, currently employed at the University of Texas MD Anderson Cancer Center as the program director and associate professor in the Healthcare Disparities, Diversity, and Advocacy bachelor's degree program in the School of Health Professions. In 2020, Dr. Lee was inducted as a fellow in the American Academy of Nursing. Dr. Lee is dedicated to the advocacy of underserved populations, and is a champion for improving global health outcomes. Thank you for joining us, Dr. Lee.
Thank you. I'm so honored to be here.
Our third panelist is Dr. Pamela Willson. Dr. Willson is a family nurse practitioner who has practiced in the roles of care provider, educator, and nurse researcher. Dr. Willson has led healthcare teams in small rural community clinics and in large urban medical centers, as well as homeless shelters and community-funded health clinics. She has taught graduate nursing and interdisciplinary health professionals for more than 35 years. As an advanced practice nurse educator, her goal is to provide sex and labor trafficking training, patient services, and support resources to aid in identifying questions to ask victims. Thank you for joining us, Dr. Willson.
Thank you, Jamie. I'm happy to be part of this important anti-trafficking conversation.
Well, let's first ensure that we're on the same page about this topic. Dr. Lee, will you please describe what human trafficking is and tell us who is particularly vulnerable to being involved as a victim?
Thank you for asking that question. Human trafficking is a form of modern slavery, and anybody and everybody are susceptible to being victims of human trafficking, whether they're adults, adolescents, or children. Anybody can be exploited to perform forced labor or engage in sexual acts against their will as a result of force, fraud, or coercion. When a person younger than 18 is used to perform a commercial sex act, it is a crime. It is a highly profitable hidden crime affecting more than 25 million people globally. And interestingly, up to 80% of victims said they saw a provider while being trafficked, but were never identified as being a victim. The Trafficking Victims Protection Act was enacted in 2000 to provide a national framework for the federal government's response to human trafficking. The Office to Monitor and Combat Trafficking in Persons falls within the purview of the U.S. Department of State and follows the 3 Ps: prosecution, protection, and prevention, with an unofficial nod to recognize the importance of partnership. Human trafficking is a global, national, and local issue and takes place in the communities where we live, which is why we must come together to fight this hidden crime. I have a slide that I'd like to share with you, if I may. This slide was actually created in 2019 as part of the Polaris project, which shows places where calls to their hotline came in. And you can see across the United States that there is no state where human trafficking does not occur. The areas in red, of course, are those that had the highest counts of calls in 2019. But you can take a look at that and see that it is a national issue.
Dr. Lee, are there certain common forms of human trafficking in our country? And could you talk a little bit about who is vulnerable to human trafficking?
Sure. Human trafficking occurs any time of the day. It happens in all settings. It affects all genders. It targets all ages. It does not discriminate. So that tells you who is able to be a victim of human trafficking. There are actually two major categories of human trafficking in the United States. The first category is forced labor, and that includes people who provide, for instance, cleaning services, who work in carnivals, who work at truck stops, work in agriculture, construction factories, nail salons, even restaurants. The second category is sex trafficking, and that includes prostitution, escort services, modeling agencies, internet-based sex, and it can be found in massage parlors, again, restaurants and bars, strip clubs, again, truck stops. People who live where they work are particularly vulnerable to sex trafficking and forced labor because of the inability to get help or escape the exploitation. As far as groups of people who are more vulnerable to human trafficking, people of color, people in communities of LGBTQ+, people who have unstable living conditions, have a history of domestic violence, substance abuse, runaways, undocumented immigrants, people who live in poverty.
Dr. Lee, are there any physical signs that may indicate someone is a victim of trafficking potentially?
One of the issues with trafficking is that there is a hidden communication system that the traffickers use for their victims. Victims are branded through tattoos or through skin tagging as a way to show that the trafficker owns the victim. And these are not viewed as people anymore. They're viewed as commodities as a means for the trafficker to make money. So the tattoos and branding are used as a form of communication within the criminal enterprises of human trafficking. Traffickers are able to carry out these horrific acts without being detected because the public does not recognize that these are signs and symbols that communicate between traffickers and people who are going to purchase these human victims. Usually the tattoos or the tags are placed on the human skin in places with high visibility. They allow the trafficker, again, to assert their ownership to the victim and to stay within that criminal network and element. They also, and I'll talk about some of them, particularly that show that the level of involvement or the status and ranking and any attributes that would make the buyer more interested in that particular victim. So you can see in some of the slides, there's not many places where the victim is not tattooed, but you can see that they are tattooed on the shoulders. They might be tattooed up on the chest, either across the chest or in one corner. You might see it on the neck, particularly on the back or on the sides of the necks. On the hands, they particularly like the fingers or the top of the hand. The arms, the forearm and the upper arm are all used. On the legs, it's usually on the thighs and the ankles. Sometimes they're tattooed on the inner lip, although that's not highly visible. It can be used so as to not be so obvious. Some of the different symbols that you see, the crown resembles ownership and wealth. The barcode is a new one that is just recently been used, and it indicates that the person can be purchased or bought. The numbers across the bottom are also significant. Sometimes it's the zip code or the area code where the person is working and being victimized, but the numbers do mean something. If there's a dollar sign or money symbols, that resembles wealth and that the status that the person is available and under the control of a pimp or a trafficker. If there are jewels or a diamond available, that also means wealth and status. If you see initials, like in the bottom right-hand corner, you see a crown, and then you see the initials. The initials are the initials of the trafficker, not of the victim. If you see chains, like in the upper left-hand corner, again, that means that the victim is under control of a trafficker or a pimp. If you see a crown, that means that the victim actually has an inner status and ranking, and that the trafficker has success and wealth. If you see a heart, that means that's an active victim. And if you see a cherry or cherries in a tattoo, that means that the victim is young.
Could you talk to us a little bit about some of the health impacts that can be seen on human trafficking victims?
Sure. These aren't going to be all inclusive, but you see things like headaches, GI symptoms. Sometimes the victims will be dehydrated or they'll appear malnourished. They might have pelvic pain from sexually transmitted infections. They might have musculoskeletal symptoms like back pain, or they might even have fractures. They could have skin problems like rashes, itching, and sores. They might have poor mental health. They might show up pregnant and have multiple abortions. They might also appear with sexual dysfunction. As for behavioral issues, healthcare providers might see paranoia, fear, mood swings. They might be frightened, depressed, or anxious. You might see outbursts of anger or intense shame, as in self-blame. They might have sleep disturbances, nightmares. They might be addicted to drugs or other substances, and they might have inconsistencies in their jobs and their lifestyle.
Now, my next question is for Dr. Willson. Can you offer some best practices when caring for suspected human trafficking victims, please?
Absolutely. Let me just share a few because there are many that healthcare providers need to heed these warning signs and symptoms. They're not unfamiliar to the healthcare provider because those are very similar to any other power abusive relationship that we see with interpersonal violence, domestic violence, child elder abuse and neglect. And that is, the simple thing is the clinical presentation does not match up to the history that is being given. The history could be memorized or scripted, and it will talk about the injury or the condition for a little bit, but secondary probing questions into it leaves the victim with no history to report to you. And there may be someone in the room with them that demonstrates this high level of control and may even provide unsolicited responses for the patient, for the history or for findings that you're inquiring about with the patient. The patient may seem fearful or anxious. They may be concerned because they've been told that they are at risk for being arrested or going to jail, dependent on whether their work status, their visas, their citizenship, etc. It's a hard thing to determine exactly what's going on when that powerful person is interjecting. And you can actually see on the faces and the body movements of the patient what is going on, that they feel overpowered at that time. With those with sex trafficking, of course, they may present with signs and symptoms of sexually transmitted diseases. There's occupational type injuries or physical ailments that are linked to work, such things as the repetitive injury of the hand, elbow, shoulders that Dr. Lee was telling us about, where it occurs in those meat, poultry processing venues. The patient's presentation can really be all over the board. It's very wide range, from the component of maybe believing no one can help them and being very submissive, to totally feeling like they are not even being exploited. Really, because they are dependent on food, clothing, shelter, or whatever they receive, they have that Stockholm kind of syndrome going on. What they have is complex trauma, prolonged exposure to this trauma of being battered or belligerent or violence or neglect. And that causes them to go into denial or have psychological numbing, dissociation. They can have rage and social withdrawal. It's just all over the place, depending on their presentation, their triggers for their violence at that point. For the provider, the best care practices are demonstrated by Doles and Miller quite well, but the very basic of it is the first and primary thing we have to do is establish trust. And so if you establish trust, you need to be open to those unfamiliar, horrifying at times stories that they will tell you. You might do that by using some of the same words that the suspect victim is using, like pressured or have to get up early, go to work, those kinds of things. Whatever they're using, you use it too, because it preserves their autonomy. And it assures that they're speaking privately, obviously. We have to speak to them privately and use a professional interpreter so that we can verify that we have empathy for them and we have an understanding of their situation, so that we can assure them that there's a way out of this trafficking situation. Now, I have a slide that depicts how we can create an environment that recognizes the impact of trauma in the lives of the clients. And trauma-informed care is a framework of thinking and intervention that is directed by our understanding of the profound neurological, biological, and social effects of trauma on a person's life. It recognizes that the patient seeking care has histories of multiple, perhaps, exposures to violence and may currently be in an abusive relationship, in an unsafe situation, and those exposed to trauma do cause health impact and how they seek care. So in summary, I think we can just say we need to, one, adapt to the individual's needs, avoid the judgment statements or actions, use open communication, use a holistic approach to implementing patient-centered treatment plans. So I guess one thing that I've heard with my students that comes to mind is that we need to ask them direct, simple questions like, do you feel comfortable telling me about your situation? Do you feel comfortable letting me in on how you got this bruise on your face? And avoid things like, have you ever been trafficked? Those yes, no questions can shut down that conversation with the person. Another important aspect is for the healthcare providers to remember that documentation is not only for the care and care team and providers of healthcare, but it is also for legal purposes. So you need to state the histories and document the physical findings objectively. You need to know the laws of your state because they vary greatly. For example, there are some states where transmission of HIV is an offense and criminalized. Also, as you're thinking about how you follow up on this patient, while there are ICD-10 codes for confirmed and suspected trafficking, and we have patient portals that are supposed to have private settings, we need to think about what is that after visit summary say? What goes on the billing invoices? What would happen if this was mailed out and the trafficker was the one that opened the mail?
Those are excellent points, Dr. Wilson. It seems that separating the suspected trafficker from the victim for a private conversation would be an essential part of providing that care. Dr. Wilson, do you have some suggestions for successfully providing a safe private space for the victim?
Yes, you're correct. It's difficult, but essential for sure. One of the few positive outcomes, I believe, that happened from COVID-19 restrictions and shutdowns are that the most common place happening for healthcare clinics and primary care especially is that only the patient can be admitted to the offices and the clinics for their appointment. Therefore, that's the usual practice and not viewed as suspicious by the trafficker. In non-COVID situations that are coming and going and hopefully will soon be over, the team needs to set a visit process in place that allows for some private times, no matter where it is, if it's in the screening room, the laboratory, the phlebotomy room, or the examination room, that we need to find that. Once that privacy is assured, then asking standardized questions, screening questions on a regular process, every patient, that is really key. It may be as easy as a positive response being recorded in your health record, your electronic medical record, that alerts the team to be suspicious for and to do further observations. An example of a warning signs for the trafficker behavior I can recall from a client that I saw in a rural Texas clinic, and they are that they demand a walk-in appointment when the symptoms did not really warrant it. I drop by, I'm coming in, you get no head start warning, I must see the provider now. And truly it wasn't an emergency. Insist on being the patient's language interpreter, aggressively insisting on being with the patient, kind of not able to wiggle them out of the room, refusing a no-cost follow-up visit for the patients or a test of cure or something that you can think of to bring them back at no charge. But all those behaviors were exhibited by a stated boyfriend accompanying a female patient that came to our clinic, and the patient's language was American Sign Language. He insisted on being with her the entire time and refused the follow-up visit, which would allow us to schedule a professional interpreter. After the exam, I contrived taking her to the lab for a fresh urine sample to use for microscopy and being able to write her a note to help clarify the situation. But providing a safe space may be difficult, but it's absolutely essential.
Those are excellent points. And my next question on this topic is for Dr. Clark. It's related to common myths about human trafficking. So we hear anecdotes and stories, even in especially social media, about children being kidnapped off the streets by traffickers, and even trafficked individuals who are physically unable to leave their situations, being locked in or held against their will. Are these myths true? And even if not, what are some common myths related to human trafficking?
Great question. You know, we live in an age where misinformation is shared all the time, especially on social media. But I think the most pervasive myth about human trafficking is that it often involves kidnapping or physically forcing someone into a situation. But in reality, most traffickers use psychological means. So things like tricking the victims, defrauding them, manipulating them, threatening them into providing that commercial sex or exploitative labor. Now that labor or that commercial sex act, it could potentially turn violent. Buyers certainly, may become violent with victims, but the idea of people being kidnapped by a trafficker, chained, locked up in a basement, it's really not the reality of the crime of human trafficking. I've heard that human trafficking is the same as human smuggling. That's not true. They're two different things. Human smuggling is a crime against a country or a crime against a state where individuals are moved. They're moved across borders. Human trafficking, as Dr. Lee mentioned, is a crime against a person where the individual is exploited. I would say news and media have made us think that smuggling is the same as trafficking, but that's not the case. Human trafficking does not require crossing of international or state borders. Victims can be trafficked in their own homes. But I should say that people who are smuggled, they are vulnerable to trafficking because of the language and the cultural barriers. So yes, human smuggling can lead to human trafficking, but they really are two separate entities. Another common myth you may have heard, all commercial sex is human trafficking. Well, you now know that that's false. All commercial sex involving a minor is legally considered human trafficking, but commercial sex involving an adult is human trafficking if the person providing that commercial sex act is doing so against their will. You have to have evidence of that force, fraud, or coercion. Traffickers only target victims they don't know. That's another myth. Many survivors have been trafficked by romantic partners, including spouses, even by family members, including parents, because we've witnessed parents addicted to drugs, who sold their children for sex, just to get money for their next fix. There's quite a bit of misinformation out there related to human trafficking. And I would just suggest give some thought before you share that news story or share that post.
That's excellent information. As Dr. Willson alluded to, the COVID-19 pandemic has absolutely changed how healthcare providers interact and care for patients in general. This is unfortunately what so many patients are seeing of their healthcare providers. So Dr. Clark, what challenges specific to the pandemic are healthcare providers experiencing when identifying and caring for these potential victims?
Yes, the COVID-19 pandemic really has exacerbated an individual's risk of being exploited in human trafficking. Just the economic impact, mainly the widespread job loss, it's left so many people unable to pay rent, unable to pay their bills. And as these moratoriums end, some individuals may still be unemployed, still unable to pay their rent. And so these factors, it heightens, the vulnerability of already struggling families. And so it can result in adults and children ending up homeless. I read an article that said that there was agreement among child advocates that COVID-19 has spurred an increase in child maltreatment. And although reporting is down, mandatory reporting is down, mainly because reporters like teachers and pediatricians, they're seeing less children, hospital reports of child abuse injuries have increased. And so the trauma of that child maltreatment, increased time on the street, and even the combination of those two things, it really does leave young people at a greater risk of human trafficking. With school closures, children and adolescents were spending more time online, learning virtually. Some still are. And so that's going to increase their risk that could lead to trafficking situations, because some traffickers use social media to recruit potential victims. But when we think about these victims who are already in trafficking situations, if they're trying to protect themselves against exposure to the virus, that can be challenging because, they may not have access to masks. they may have no choice as to whether to wear a mask or to insist, that others around them wear a mask. And even social distancing, it may be difficult, if not impossible, in these settings. But when trafficked individuals present at hospitals, some of those protocols made necessary by the pandemic present new barriers for healthcare professionals who are trying to build that caring relationship that Dr. Willson mentioned. And so wearing masks, other protective, equipment, that may make it harder for healthcare professionals to connect with trafficked victims and build that trust that enables them to open up and share what they are experiencing. And then adaptive strategies like telehealth services, they may not work as well because, some trafficked individuals have lifestyles that make it difficult to attend a scheduled telehealth appointment, or their living arrangements may not permit, the privacy and confidentiality appropriate for that patient care. They might just lack the necessary computer equipment for a telehealth visit. So yes, the pandemic is yet another barrier for healthcare professionals to have to overcome to identify and connect with trafficking victims.
So with the stay-at-home orders that came out of COVID-19, the travel limitations, loss of jobs, we're seeing an increase in gender-based violence and substance abuse. Dr. Willson, I'm going to come back to you for this one. Since March of 2020, telehealth has replaced many in-person healthcare provider visits. So what effects has this telehealth visit decline had on human traffickers exploiting vulnerable populations?
Oh, thank you for this. And I'll just follow up on what Dr. Clark said. It is just barrier after barrier after barriers put in front of us. And it's not unusual in your neighborhood probably for you not to see the cars move out of the garage or the driveway. There's no activity. So you're not suspect. The normal people, as you mentioned, the healthcare providers, the teachers, the pediatricians, but even the neighbors are not aware. So with telehealth visits, it's even more likely that we might miss or not pick up on all those, warning signs and symptoms of trafficking that we talked about earlier. It's because there's only part of the team available to our patients. It's usually just a healthcare facilitator and a healthcare provider that are having this interaction. And if they have the resources, as Dr. Clark mentioned, the computers and or cell phones, or if they have those things at all, we are missing part of the team and part of the steps in identifying, from the time of appointment all the way through the exit and payment schedule. So that is a difficult thing. One of the strategies that you can do is request that the patient only be in the room behind closed doors and that they're using headphones or earbuds, but that might not be a possibility for them. You can have the patient scan the room with the device to provide the provider with some view of the surroundings. And then, of course, if you can discern that there's privacy and they're safe, you can ask those human trafficking questions that we spoke about earlier. At that visit, if you're so lucky as to get it and to meet those criteria, you need to provide them as much as possible, because this might be a one-stop shop opportunity to give them hotline numbers, reporting methods, to set up a time for a follow-up, determine the present interaction is in accordance with their safety plan or their present safety. And you can perhaps do that by possibly determining whether they have phone accessibility, unmonitored, or times that they're alone. Perhaps it's at the place of work where maybe a social worker might meet them, and give them some empowerment in their voice. In being able to take care of themselves. And you have to do it rapidly and still at the same time build trust. Gerber and colleagues stated some trauma-informed telehealth strategies that kind of sum it up. Number one, safety, which we've talked about. Verify the environment of secure and private, and get medical consent and use of those headphones and earbuds. Trustworthiness and transparency, be that active listener so they can see your body language, that they can see that you have good eye contact. Collaboration and mutuality, thank them for sharing those difficult stories with you. Collaborating with them on how to set the agenda and whether they want to end the visit right then and there. That they need to be in charge of it and know they have your permission to do that so that they can remain safe. Empowering their voice and choice. And as always, the cultural, historical, and gender issues, just remembering those social determinants of health and being sensitive to the patients, revealing their experience during the venture.
Thank you very much. So my next question is for Dr. Clark. Some healthcare facilities need to develop policies related to human trafficking, whether it's policies on screening potential victims, making referrals to social workers, mandated reporting, or providing clinical care. I would imagine that coordination with local law enforcement is certainly also an important component with policy development. What are some things that healthcare professionals can consider when creating these policies and working with local law enforcement?
Great question. In my work, I came across HEAL Trafficking, H-E-A-L, HEAL Trafficking. They actually provide a toolkit that helps with developing policies. And these policies are related to screening, the referrals, mandatory reporting, clinical care. You can actually do a Google search for HEAL protocol toolkit and find it. But the toolkit presents a lot of questions for your team to consider. So things like documentation that Dr. Willson mentioned, establishing a partnership with local advocacy groups and religious organizations, that mandatory reporting, as healthcare providers, we're mandated reporters, not mandated interveners, but we are mandated to report. Trauma-informed practices. Dr. Willson did a great overview on some things we can do. My background's RT, radiology, and so I think so many times, especially like in the emergency department, we knock on the door, but we just bust in the room. Hey, I'm Kevin from radiology. And with these victims, knock on the door, peek in and ask, is it okay if I come in? If they tell you no, respect that, and say, hey, I'm gonna check back in 5 minutes. But that trauma-informed care is so important. But the toolkit also mentions survivor-informed resources where, institutions should try to connect with survivors and get input from them, those individuals who've managed to get out of the lifestyle, and find out, what are some of their needs? What are some good questions that you could ask in that private, safe, healthcare setting? You'll probably want to consider who you want to be on your response team when you identify a potential victim. Does the receptionist need to be in the loop? It could be that the receptionist isn't the best actress. So, if the receptionist is aware that you're suspicious of trafficking, what if she freezes and she can't even speak, when the trafficker comes up to the window and asks, how much longer? So just give some thought as to who you tell and who you involve. If you're at a small clinic, how do you get law enforcement or security involved? The toolkit says that you really need to consider determining law enforcement's their enforcement policy on arrest and detention of victims of crimes. And these crimes can be related to their victimization, or maybe just past crimes where victims may have an open warrant for their arrest. And so you have to be aware that if your policy says, hey, I need to call law enforcement in, they arrive to interview a potential victim and they find out that the victim has been charged with the previous crime, has a warrant out for their arrest, then state or local laws may require the officers to arrest the victim. And if the victim is arrested under your care, then your healthcare environment, your institution is no longer a safe place for them. With Dr. Willson mentioned documentation, so I don't really need to speak on that again, but She also talked about, the overpowering person who accompanies the victim. If you need to interview victims and you really can't seem to get alone, the toolkit suggests writing policies for separation, like asking the controlling person to step aside. Maybe, hey, come down to the nurse's station to fill out some paperwork, or hey, come down here, you need to make a phone call to schedule an upcoming radiology visit. With safety, I think it was mentioned, maybe consider flagging the patient's record so that if someone calls, regarding their whereabouts, then all staff will deny the presence of the individual at the facility. But the protocol toolkit is highly recommended for institutions that need to develop policies for human trafficking.
That's excellent information. So Dr. Lee, I'll take it back to you. In addition to the policies and involving law enforcement, are there other resources available for victims and for healthcare providers who care for them?
There are. That's a great question, and thank you for asking that. I did a quick search to see what was available and what I could find, and came up with several. But these are really good ones. For victims, the National Human Trafficking Hotline is a good one. They are open 24/7. They provide assistance in more than 200 languages. They have not only a website, they have an 888 telephone number, so it's free to call. They also have a text method of victims contacting them. I mean, the victims need to remember that the number is 233-733, but all they have to do is text help or info, and they are in with the National Human Trafficking Hotline. In Houston, we're fortunate that in Houston, we have an organization called Unbound Houston, and other cities have the same kind of thing. And this organization provides advocates for the victims who need somebody who really understands what's going on. They are able to establish safe relationships with their advocates. There's another one that I did not find on a logo for, and it's the SOAP project, and it's called Save Our Adolescents from Prostitution. There is a website for that, but adolescents can contact them for help. For healthcare providers, as Dr. Clark has talked about, there is the protocol toolkit, and here's the logo, the Health Education Advocacy Linkage. And their logo is because human trafficking is a health issue. So for healthcare providers, they provide tremendous resources. There's also the Texas Department of Family and Protective Services. They have an 800 number. They also have a Texas Abuse Hotline that can be called. If just to remind healthcare providers, if the sex trafficking involves a minor, there is mandatory reporting, and that occurs with Texas Health and Human Services, with the Child Protective Services.
Thank you very much for that thorough list. So Dr. Lee and Dr. Clark have spoken about human trafficking resources that are available, some of the warning signs of persons being trafficked. Healthcare providers' priority is certainly to obtain training, followed by ensuring that screening protocols are in place at primary care practices, in educational settings, or even in community and faith-based organizations. Dr. Willson, would you please talk to us about any recommendations you have for implementing screening in a primary care clinic?
Oh, that's a wonderful question. Thanks for giving it to me. I am so glad to be building on what has been discussed by Dr. Lee and Dr. Clark. But my strongest suggestion is to remember that screening for work and sex trafficking is that it is a team effort. And by that, I want to emphasize the importance of gathering sometimes very subtle data that adds up to the recognition of a person being victimized. You know, you have to know your team, and they have to be well trained, and they need to be good actresses if they're on this team, for sure, as Dr. Clark said. But remember, it's the front desk clerk in a small primary care clinic that may be the only person that witnesses the trafficker controlling the patient's schedule, their documents, their insurance card, their money. It might be the nurse or the provider that might hear this evasive rationale for some physical or psychological abuse. And it may only be the front office staff that observes the argument that's, in taking place for setting the next appointment. So when the entire team is observing for these patient safety, the patient's safety, and has a method of confidentially communicating this information among the team members, as Dr. Clark mentioned, maybe an alert to the electronic health record, then the potential diagnosis of human trafficking can be made and or referred. So we know that healthcare professionals are good at taking the leadership of implementing those trafficking protocols and team education and periodic team meetings. And however, anyone can be a team champion. And I've witnessed that at large institutions that I've worked at in metropolitan areas where there are many employees and multiple shifts, and there's been super user team strategies utilized for that so that everyone at work is educated on human trafficking, warning signs, etc. And since the healthcare providers, the doctor, the nurses, the radiologists, the PAs, the social workers, etc., are mandated to have the human trafficking professional education requirements, they're usually good at being able to share those information, warning signs, and how to approach the screening and management of the victims with the entire team. But it's those toolkits, those templates, that forethought, looking at it ahead of time that was mentioned by Dr. Lee and Dr. Clark, that really we need to implement. I'd also like to say that when you're working with that team in educating about human trafficking, that we need to take it up from just awareness and knowledge to how to implement it. And we have research studies that show that simulation and role play are just excellent educational tools for healthcare providers, students, as well as team members, in getting them to feel more comfortable, because those are very difficult conversations and stories that we will hear. And it's that kind of thing that will increase not only the knowledge and awareness, but also how to implement. And this team needs to think about the team caring for the person that's trafficked. It takes a toll on healthcare providers, and you need that support of the team. So I really encourage meeting on regular scheduled times and discussing it, and talk about what went good and what didn't go so well, and how you can improve it in the future, and what more resources or that you need in the community, or just an overall evaluation of it.
That's excellent advice. Thank you so much for sharing. My next question, which is my final question, is for Dr. Clark. Are there legal avenues that we can provide to help relieve victims of some of their crimes that you mentioned earlier related to trafficking?
Yes, so it is common, quite common, for survivors to have a criminal record as a result of being trafficked. And so some states will work with survivors to get those activities or those offenses that they were forced or coerced to participate in removed from their record. Dr. Lee mentioned the Polaris Project, maintaining the National Human Trafficking Hotline. They do a lot of research, but they actually give every state a grade based on their laws related to that criminal record relief for trafficking survivors. So you can go to their website, pull up your state, you can see what the grade for your state. They also rank them in terms of, that relief. But a criminal record, even an arrest without a conviction, doors are going to be slammed shut on these people. It's going to be harder to find a job. They're probably not going to be able to rent an apartment. And here they are trying to rebuild their life after breaking free, from this trafficking situation. And then all of these doors are slammed shut. So you guessed it, many survivors go back to the lifestyle, and the cycle of exploitation starts all over again. That's two things here. That's why it's so important to vote, because our legislators make these laws. And so it's so important to be involved, but then also as providers to be advocates. Certainly we're advocates for all of our patients, but we really need to give some thought and some consideration to our trafficking victims so that we can help them, know that help is available and let them find a way out of that lifestyle.
Thank you so very much. And thank you to all of our panelists for joining us for this important discussion. We'd like to share the contact information for our panelists, Dr. Lee, Dr. Wilson, Dr. Clark. Please feel free to contact these experts with any questions. Their contact information is available on the screen. Reach out anytime. And again, we appreciate your attention to this matter.